Hi everybody, this is a physiotherapy site initiation video for the Australian rotator cuff trial. Now the background for this trial is that we don't have good evidence that surgery to repair a degenerative rotator cuff tear is better than non-operative treatment. So therefore we're trying to generate the evidence around this by doing a blinded study, a placebo-controlled study. So the aim of the study is to determine the effectiveness, safety and cost effectiveness of arthroscopic rotator cuff repair compared to no repair, but arthroscopy, looking at pain, function and quality of life. The study's already been cleared to start. It's been approved by all the relevant ethics committees. This is a list of the surgeons and sites we have so far, and so it's to physiotherapists in these areas that I'm addressing this. Brief points about the study is that patients will be identified and recruited from the surgeon's practices. They have to be between 45 and 75 years of age with a MRI proven rotator cuff tear. Minimum target is 142 patients from these 5 sites. And the study design is that it's a blinded RCT. The process in surgery is that eligibility is confirmed intraoperatively. So during the arthroscopy, the surgeon will determine that there's a complete tear, that it's the right size, that there's no other pathology that would exclude them. And only then are they randomized. So patients are randomized intraoperatively using an online system to either have repair or no repair. If they're not eligible for the study, they'll just go on and have whatever care the surgeon thinks is appropriate. After surgery, everyone will be blinded. So recovery and ward staff will be blinded. Theatre staff in the operating theatre obviously will not be blinded, but they must not reveal what the patient had. And even the operation notes will not say what they had. So the consent form and the operation report will say surgery according to the ARC protocol. So it won't say whether they had a rotator cuff repair or no repair. Now in hospital, we want the physios, if it's usual practice, to see them at least once afterwards and give them instructions on phase 1 of the rehab. So this is where the physios come in. Now after discharge, of course, it's going to be all physio, at least for the first few months. You must maintain participant blinding. You will be blinded. The idea is to not find out. The primary outcome is measured at 6 months, but patients will be followed up for longer than that. So we want to avoid any imaging, no X-rays, MRI scans, because it might show the anchors, the repair anchors. Now, prior to discharge, we will give patients a letter to hand to their physio, a booklet of the physio guidelines, which is a very detailed booklet of exactly what protocol we want them to follow, and also just a small physio exercise pamphlet for the patients to keep. But the physio guideline is for you, but you should be getting copies of this if you're involved in the study anyway. Now the protocol itself, as I said, is 2 halves. There's the guidelines that the physios have, and there's an exercise pamphlet that the patients have. So these are all provided to the patients and to the physio departments in public hospitals, but you can download these from our website at arcstudy.org. The protocol has been adapted from the ACCURATE study, which is a similar study being done in Finland. It's also been adapted from best practice guidelines from the US. It's fairly standard stuff. It's reasonably, it's a common practice, and it's very evidence-based. So there's nothing unusual in the post-op protocol. All of the surgeons have agreed with the protocol, and physios have been involved in the development of the protocol. So we want all the participants, whether they had a repair or not, because they don't know, to have the same rehab protocol for 20 weeks. There's 4 phases, progressive phases built into it, and we want we expect them to attend around 11 sessions, plus doing their home exercises. They start with sling immobilization for 4 weeks, except for showering and exercises. We want them to do 3 or 4 exercises each time. And they need to have no or minimal pain. So it needs to be 0 to 4 on a 10-point numeric rating scale during the exercises before they can progress to the next phase. Participants may proceed slower through phases if they're having problems, but they can't go faster through the phases. These are the important points. I'm not going to spell out the protocol. A lot of you know it. You'll have it in front of you. But these are the important points about graduating from one to the other and not going too fast. So these are the contacts. That's me, Ian Harris. Nancy is our trial coordinator. Shirley is the academic secretary. The phone number there you can get us all on, and you can check out the website and you can email us. Thanks very much for watching.